everybody. I hereby open this academic ceremony in which Rawia Abdalla will defend the academic thesis Health Outcomes Measurement for Value-Based Healthcare, Evidence from Saudi Arabia. May I invite you to present a summary of your study and the conclusions of your thesis.
Of course, thank you very much. Dear Prorector, members of Corona, supervisors, audience, family, and friends, in 15 minutes, I'll present a summary of my thesis titled Health Outcomes Measurement for Value-Based Healthcare, Evidence from Saudi Arabia. And starting with a brief background about the topic. In recent years, there has been an increasing demand to change the healthcare landscape from the traditional volume-based healthcare into value-based healthcare. The volume-based healthcare focuses on the quantity and volume of healthcare services provided, regardless of the outcomes achieved, leading to resource over-utilization and increased healthcare costs. In these models, providers are incentivized to conduct more interventions and tests that are not necessarily linked to improved patient outcomes. While in value-based healthcare, the focus is on health outcomes achieved, the health outcomes achieved for the patient at lower cost. And this is basically the definition of value. Providers in these models are paid based on their performance in certain quality measures that reflect health outcomes and value in terms of CROMs, clinician-reported outcome measures, PROMs, patient-reported outcome measures, and PREMs, patient-reported experience measures. In these models, or in this approach to value-based healthcare, the patient outcomes are promoted and the overall effectiveness and efficiency of healthcare services are improved. These positive attributes of value-based healthcare have led many countries to start their transformation journeys into these healthcare delivery systems, including Saudi Arabia, that is indicated here in this small map. The country, Saudi Arabia, has developed this 5-year plan for the transformation into value-based healthcare. Comparable to other worldwide initiatives in Netherlands, in USA, and other countries, this plan started with data standardization and informatics, with a collection of what's called the minimum data set, including key relevant indicators used for value-based healthcare, of course, outcome measures, followed by outcome measurement and benchmarking. And at this stage, the focus primarily was on PREMs rather than PROMs at this stage in this transformation to the new healthcare delivery system, followed by introducing cost metrics and analysis, piloting and testing diagnosis-related groups as payment systems, and ending up with value-based bundle payment tested most probably in the coming year. Although this plan was developed by the Saudi Council of Health Insurance, that is one of the entities responsible for the implementation of value-based healthcare in the country, the strategies and the methodological aspects of outcome measures were not specified at the national level, leading to a state of indecision or confusion for hospitals and healthcare organizations on how to implement value-based healthcare. Accordingly, the central aim of my thesis is to understand health outcomes measurement in hospital value-based healthcare in Saudi Arabia to facilitate the transformation into this new model. To gain this understanding, our first objective was to conduct a systematic review of the literature to identify quality measurement practices in hospital value-based healthcare programs. Here, we anticipated that a large number of medical conditions would be generated or identified. So our second objective was to conduct a cross-sectional study to assess the top priority outcome measures for hospital value-based healthcare programs. The aim here was to develop a general set of outcomes that can be used or applied for patients from different medical conditions. And to answer the question whether to include PREMs that is patient experience in value measurement or not, and what is the importance of patient experience in this realm, our third objective was to conduct an observational study to assess the association between clinical outcomes and PREMS to inform value-based healthcare reform. And finally, to understand the barriers and the challenges that hospitals encounter during their transformation journeys to value-based healthcare, our fourth objective was to assess these barriers and also to provide or propose strategies for improvement in order to facilitate this transformation to value-based healthcare. In Chapter 2, we conducted a systematic review of the literature on quality measurement for cardiovascular diseases and cancer in hospital value-based healthcare. And here someone may ask, why cardiovascular diseases and cancer? Actually, we focused our review in these two medical conditions because they have a well-established quality measurement practices developed by the cardiovascular diseases and cancer communities. And as these medical conditions include a wide range of diseases, we anticipated and we believed that focusing the review in these two medical conditions would enhance the opportunity for us to identify a wide variety or the wide variety of outcome measures that can be measured for patients with different medical conditions. Our search in this systematic review yielded 2,860 publications. Among these, 37 studies were included in the analysis. We found in these studies that there was a consensus to include clinical outcomes like survival, for example, complications, adverse events, and also patient-reported outcome measures, most importantly, quality of life, including functional status of the patient, symptom management and control, pain, anxiety, and others. In these studies and the programs that we reviewed, we found that the standardized outcome sets that were used in these programs provided a comprehensive health outcome measurement per medical condition, providing details on the types of health outcomes that need to be measured for value-based healthcare, type points, tools, and other important aspects of outcome measures. This led us to the conclusion that hospitals can adopt these standardized outcome sets. Still, they can develop their, but they need to ensure that their practice can be compared to other peer organizations, facilitating comparisons and benchmarking at national and international levels. It's important here to note that these standardized outcome sets are disease-specific and are developed per medical condition. So for hospitals that treat a wide range of medical conditions, it could be overwhelming or challenging for them to implement all of these standardized outcome sets for all medical conditions. So in Chapter 3, we prioritize the outcome measures for value-based healthcare. Our aim here was to generate a general set of outcomes that can be used as a first step, let me say, in the transformation to value-based healthcare. Here, we focused on physicians because they have the broad understanding of health outcomes experienced by patients with different diseases. We asked 204 physicians to complete a questionnaire prioritizing 30 health outcomes extracted from more than 60 disease-specific outcome sets that I mentioned in the earlier slide, classified into 6 domains of Michael Porter outcome hierarchy. We asked them to prioritize them based on their level of importance on a scale of 1 to 5. Here in this exercise, the physicians prioritized overall survival rate, quality of life, time to treatment, and other clinical outcomes like incidence of adverse events, need for retreatment, and of course, hospital-acquired infections. By this prioritizations, we established a general set of the most important outcomes that applies to patients and can be considered as a first step in the early transformation to value-based healthcare. Our findings in these 2 studies and 2 chapters supported the inclusion of CROMS, clinician-reported outcome measures, and PROMS, patient-reported outcome measures. But still, many healthcare organizations and even providers are skeptical about the role of patient experience, expectations of the patients in value measurement. To answer this and to check association and to what extent they are consistent and congruent, our study in Chapter 4 assessed the association of patient experience and the quality of hospital care. We have done this to check and identify whether patient experience provides a consistent evaluation of the quality of hospital care to that provided by other objective measures like clinical outcomes, for example. And we found that patient experience scores are, or higher patient experience scores are correlated with lower clinical outcomes, like hospital readmission rate, length of stay, central line-associated bloodstream infection, catheter-associated urinary tract infection, and surgical site infection. In other terms, patient experience or patients treated in hospitals with better performance in these clinical outcomes would be satisfied, would have higher patient experience scores, and their journeys in the hospitals would be better. So patient experience or PREMS complement other objective measures of health outcomes, thereby contributing to a comprehensive and more value-based evaluation of healthcare services. However, this comprehensive evaluation that includes CROMS, PROMS, and PREMS would not be feasible for many healthcare organizations that are still in the early stages of transformation to value-based healthcare, like many hospitals in Saudi Arabia, because of challenges, barriers related to resources, infrastructure, support even for this transformation. To identify and shed the light more on these barriers, in Chapter 5, we assessed these barriers that hinder the implementation or the measurement of outcomes for value-based healthcare in Saudi Arabia. We interviewed 16 chief executive officers and chief medical officers to identify the most common barriers for this transformation. These hospital administrators, following the theoretical domain framework, identified the lack of knowledge and immature culture of value-based healthcare among the most common barriers to this transformation. They reported that healthcare providers and hospital staff were not aware about the concept, basic principles, benefits of value-based healthcare, and how to implement value-based healthcare. In addition, they mentioned barriers related to, of course, resources and infrastructure, IT solutions, and time constraints and workload demands and business overlapping or competing business demands and priorities, especially for physicians. To provide and to propose strategies for improvement, we utilize the behavioral change wheel with its 3 key elements to enable change. In our case, the change is the transformation to value-based healthcare. Starting with strengthening the capability of the entire healthcare system and the capability of healthcare providers and staff as well, by providing training, knowledge, opinion leaders who can provide on-site guidance and information for hospital staff, and piloting value-based healthcare at low scale before the large-scale implementation of value-based healthcare. It's also important to provide the necessary resources and capture every single opportunity to enable the transformation to value-based healthcare by providing automation, resources, tools for the staff. Standardization and benchmarking are also very important, as highlighted in this thesis. Without motivated people, engaged, interested people who show high buy-in in this transformation, it would not be feasible. So hospital leaders need to consider rewarding incentives, and they themselves need to be on board and engaged in this transformation so others will follow and have really successful transformation into value-based healthcare. So these hospital leaders included in this study and in others, they need to consider robust strategies to overcome these barriers and facilitate the transformation into value-based healthcare. This dissertation has contribution for key stakeholders in this transformation. For patients, it fosters patient-centered care and empowers shared decision-making by emphasizing the importance of collecting data and using this data, data on PREMS, PROMS, and CROMS, using that to guide treatment plans and to engage patients patients in making decisions related to their medical treatments and medical conditions. For healthcare providers, it promotes data-driven decisions and fosters outcome-oriented care by using this data that is collected to drive their decisions related to patients' treatment and care plans. For regulators, it emphasizes the standardized measurement of outcomes that facilitate comparisons and benchmarking at national and international levels, and also it offers the strategies that I mentioned to overcome the challenges and the barriers to the implementation of value-based healthcare in the country. And finally, for payers, it emphasizes the importance of linking financial rewards to health outcomes identified in the in the implementation of value-based healthcare that can, at later stage, promote cost-effective analysis for the country and at wider scope. Thank you very much for listening, and I give the word back to the prorector.
Thank you very much. We will now start with the opposition, and the opposition will be opened by the chair of the assessment committee of your thesis, Professor Van Meerode. He's Professor of Logistics and Operational Management in Healthcare at Maastricht University.
Yes, thank you very much. Dear candidate, I want to congratulate you with your thesis. This is a very good and fine thesis. Also, congratulations to your supervisors for this extending very good work. I will ask some questions. I would like to go into discussion with you. I first want to explore some concepts that you use, and then I will want to go deeper into value-based healthcare. But start with the simple question, but maybe not a simple answer. What do you think is value? And not as you had defined it in your thesis, but just in general, what do you think is value?
Of course, value is what matters to a highly esteemed opponent. Thank you for your kind words first, and for this question. Of course, value is what matters to patients. All value-based healthcare is to prioritize what matters to patients and to measure what the patients value most. So the focus is on the patients. Whatever matters to the patient is value. The patients are our end customers in the healthcare system. And all the healthcare system, the whole cycle, all of us, all the healthcare providers are working to improve this value for the patients. So for value, from my understanding, is what matters to patients, whatever it is, related to clinical outcomes, related to outcome measures, patient-reported outcome measures or symptoms experienced by the patients, or even patient expectations are of value for me and I think for all healthcare providers.
Yeah, and thank you. And in your second chapter, you do a literature review to quality. Supposing your thesis I change everywhere value into quality, would that make any difference?
Yeah. Thank you for this question, highly esteemed opponent. Actually, value, as I started in the scope of my thesis, we started actually in the second chapter by identifying the quality measures of that people use or healthcare providers use to assess the quality of healthcare services. And in that chapter, we started the systematic review by the three components as per the Dunapedian model. We included process measures, we included structure measures, and we included outcome measures. This was like a big umbrella and an entry to our understanding of outcome measurement for value-based healthcare. And based on our findings in chapter 2, the systematic review, we found that yes, we started with quality measures with these three Dunapedian model components, but the focus shifted later on at later stage on outcomes based on the results of the systematic review and the literature review we conducted in other chapters, with highlighting the role of outcomes more in assessing the value of healthcare services as true measures, visible measures for patients and for healthcare providers.
So we have outcome measures and we have cost measures, and with quality you especially look at the outcome measures. When you defined value, you said what matters to patients. In the later part of your presentation, you also mentioned cost effectiveness analysis. Is that the same? Because in tradition of cost-effective analysis, one takes a societal perspective. So also outcomes and costs, which are not patient-related, which do not matter, the patient may be involved. So is cost-effectiveness analysis not more advanced than value-based healthcare in the way you define it?
Yeah, thank you for this question, highly esteemed opponent. Actually, it's important. This is a value. The value formula is the two components, health outcomes and cost. So it's very important. I can't say that it's not important. We need to consider cost effectiveness and cost analysis because providing healthcare services at lower cost is important for healthcare providers and for the patients at the same time, because the patients, yes, they want to have better outcomes, but at the same time, not to pay a lot to achieve these health outcomes. So cost-effective analysis is part of the value formula, and we cannot exclude it. Maybe in this dissertation, in my thesis, we did not focus a lot on cost because the scope of the dissertation was to identify the quality measurement practices and more on the numerator part of the value formula rather than the cost-effective analysis. But at later stage, definitely this needs to be analyzed in the country and needs to be included in the transformation to value-based healthcare.
Yeah, but I do not totally agree with you, because you are only including the costs and outcomes within the healthcare sector. And in cost effectiveness analysis, you should also consider costs and outcomes outside the healthcare sector. For example, if a patient is very satisfied and is healed, but still has sickness leaves with an employer, then the employer incurs costs, and these are not included in your value-based payment system. So I would say cost-effective analysis could be more advanced than value-based healthcare.
Yeah, hi, Steve. Thank you for this comment. Exactly. Now, for the health outcomes achieved or measured in value-based healthcare, it can be like in levels. Now, in the country, in Saudi Arabia, we are still far away from what you have just mentioned, because we are still establishing the cost metrics for the basic, let me say, or fundamental health outcomes measured in the country. This can be done at later stages, but we are still in the foundation of establishing these metrics and testing and piloting cost analysis for health outcomes.
Yeah, that could be, and that's a change management policy. But you could also say that the definition of value-based healthcare by Michael Porter, by his discussion of integrated practice units, is in fact let's say a lower level of ambition, because it in the definition is included that you restrict the scope of the cost effectiveness analysis, namely purely to a certain segment of healthcare. So why don't you, why would just a thought experiment? You could advise the Syrian government to follow a two-stream approach. So promote value-based healthcare, at the same time do a cost-effectiveness analysis of each new procedure that is introduced in the healthcare market. So you do cost-effectiveness analysis on the country level, and a value-based healthcare management at the institutional level. What do you think about that?
Yeah, thank you for this question, highly esteemed opponent. Actually, this has already started in the country. We have a new center established, that is the National Case Mix Center of Excellence, responsible for what you mentioned about establishing cost analysis and cost metrics with specific procedures. For example, cataract, we started in the country. So this has already started, but as I mentioned, it's in the early stages. So the foundation is still evolving for cost metrics, and cost-effective analysis. But already this has started, and definitely this needs to be considered, as you mentioned, in the change strategy or the transformation strategy in the country.
Okay, thank you. Thank you for your answers. I'm satisfied. I give the word back to the pro-rector.
Yeah, thank you very much, Professor van der Rode. The opposition will be continued by Professor Aboushayka, Professor of Nursing at Maastricht University, Riyadh, Saudi Arabia. Welcome, Professor Aboushayka. The floor is yours.
Thank you so much. Good morning, Rawia. How are you today?
Thank you very much, highly esteemed opponent. Thanks. I'm fine.
I'm so happy today to see that this is a great job. We're really proud of this great dissertation work. Since I'm from Saudi Arabia, and I'm so glad and happy to see such a great job. I have a question and I have a comments. My question is, I'm a nurse and you're a nurse also, and my question is, where is the nursing role from this great job? From because as you know, we are the nurses. We are like 50 to 60% of the manpower in hospitals. So I don't see your dissertation. You didn't include the nurses' perspective, since we are the huge manpower in the hospital. So tell me, what is the nursing role they can play here? Then I'll come back to my comments.
Highly esteemed opponent, thank you for this question. I want to echo what you just mentioned about the importance of nursing role in value-based healthcare. When it comes to CROMs, like clinician reported outcome measures and patient reported outcome measures, nurses play a major role in providing the information for the patients on the why the healthcare providers are collecting such health outcomes. So nurses are the first contact point with the patients for data collection. As I mentioned earlier, values about the patients and outcomes, especially for patient-reported outcome measures, come from the patient. So nurses usually collect this PROMs from the patients. In other countries, physicians do, and this is the practice, for example, in the clinics and everywhere. But nurses' role also is important to ensure the credibility of data, the accuracy of data collected from the patients by explaining to the patients the questions, for example, in the questionnaires of PROMs, to ensure that the patients understand the questions there, the time points. Some patients may give like an indication or answers for what they experience at the moment when they are asked. But you know, PROMs are at different time points. So this needs to be explained for the patients. Nurses have more time to spend with the patients compared to physicians with heavy, or busy clinics. So I will emphasize the nurse's role in PROMs and also in CROMs, clinician reported outcome measures in patient settings when the patients are admitted. The nurses also collect such measures and emphasize the importance of using these measures to adjust, and to modify the treatment plans for the patients.
So my recommendation, maybe when you relax and finish your PhD, maybe we can conduct a study of the nursing perception of the value-based healthcare. It's what I recommend for you. My comments is, and let's go back to your recommendation. You recommend we start with the training and increasing the capacity of the healthcare providers, and this what there is a big center, the center of health for value-based care in Saudi Arabia. This is a new center they started, and I am taking now intensive course with them. It's a 9-month course. It's a 9-month course with like around 10 modules from the basic to advanced. So this is a great it go up, it match with your recommendation. So they are doing a lot of big trainings, training for all the healthcare providers in Saudi Arabia. It's an online program. So I am done, and thank you so much. I'll go back to the chair.
Thank you very much, Professor Abu Shaikai. The opposition will be continued by Professor de Jong, Professor of Healthcare System and Governance at Maastricht University.
Thank you. Well, dear candidate, I also would like to compliment you and your team with your great work. You have written a very interesting and important thesis. Well, your thesis is about health outcome measurement for value-based healthcare, and in chapter 3, you describe your study on the physician's perspective on prioritizing outcome measures and a set of most important outcomes that apply to all patients was established. In your discussion with Professor van Meerode, you also mentioned that value is what matters to patients. And how were patients involved in prioritizing outcomes?
Hi, Steve. Thank you for this question. Of course, undoubtedly, patient perspectives are important for value-based healthcare, and the whole program or the whole model is about what matters to patient, as you just mentioned. In our study in chapter 3, the scope of our study was to generate a general set of outcomes that can be applied for patients from different medical conditions. And we focused on physicians in this study rather than patients, not underestimating the role of patients, as you mentioned, but the scope and to answer the question of the research study in order to give or generate a general set of outcomes. Physicians' perspectives were deemed essential for this understanding, including patients in such prioritization methodology or exercise that we have done in chapter 3 could create some, I don't want to say bias, but a shift on the focus of the scope of the study on outcomes or health outcomes experienced by patients with certain medical conditions, the patients who accepted to enroll in the study, while our scope and aim was to create a general set of outcomes that can be applied for different medical conditions. So to ensure that we answer the research question within the whole thesis, we focused on physicians because they have this broad understanding of health outcomes experienced by many patients, not certain medical conditions of patients who accepted to be part of the study. So that's why patients were not included, but of course, their perspectives are important.
Yes, I understand, but it still is the perspectives of physicians. And do you expect that the priorities of patients would be the same?
Thank you for this question, highly esteemed opponent. It could match, of course. In the prioritization, the priority list that the physicians prioritized for outcome measurement in value-based healthcare, we saw, as I presented in the presentation, for example, survival, health-acquired infections or hospital-acquired infections, length of stay, which could, to high extent, match with patient priorities. So they are, let me say, consistent with each other. We expect that patients would prioritize these measures, and accordingly, we recommended to healthcare organizations to start with this general set of outcomes as a first step in their transformation.
And do you think it's important also to test whether priorities are similar between physicians and patients?
Thank you for this question, highly esteemed opponent. Yes, let me say a cross-check between the list that was created by the physicians, and at maybe later stage we can also do this evaluation or prioritization with the patients and come up with a general set with including both perspectives, the physicians and patients, to ensure that both perspectives and insights from both sides are there, of course.
Yeah, well, it's also because you state in one of your statements that early engagement of both patients and providers fosters their commitment, but I wondered how do you see that in practice?
Thank you for this question, highly esteemed opponent. Yes, now this is consistent with what is being done by, for example, ICHOM, the International Consortium for Health Outcome Measurement, and other organizations at international levels. To develop the standardized outcome sets, they include key stakeholders. These key stakeholders, like, for example, physicians, patient representatives or patient groups, and patients themselves in the development of these standardized outcome sets. And this is what I emphasized in the thesis. I also emphasize now that these key stakeholders, even insurers and others, all need to be on board on the same table to establish and to generate or create this standardized set of outcomes to ensure that they are really comprehensive and provide in-depth insights about health outcomes for different medical conditions. So perspectives from healthcare providers, administrators, insurers, and even regulators need to be considered in the development of outcome measures for value-based.
And how would you do that?
You mean in Saudi Arabia or
in Saudi Arabia? Yes, for you.
yeah, exactly. Now, at the national level, highly esteemed opponent, we have, as Prof. Abu Shaiga mentioned, we have centers, different entities that work on value-based healthcare. They started actually to work on or to adopt some standardized outcome sets from like ISHOM or any other entities, and to include patients and healthcare providers to recommend the top priority standardized outcomes measures that needs to be, established in the early stages of the transformation. So this is being done. Patients are included, representatives from patients and healthcare providers in this at national level.
Okay, well, thank you. I have some other questions about chapter 4, where you have PREMs, and they are measured at the hospital level, or at least you included them in your analysis at the hospital levels. And I wondered, because they were measured at patient level, do you have any idea about the response rate in hospitals?
Yeah, highly esteemed opponent, thank you for this question. Yes. PREMs at this stage in the country, and let me say in most of the hospitals in the country, are measured at hospital level. So we cannot track, for example, the PREMs of a particular patient. It's anonymous, PREMs and other questionnaires given to patients are anonymous. So we cannot track the responses of a particular patient and link it with the clinical outcomes experienced by that same patient. That was the difficulty for us to conduct the study at patient level. So it was conducted at hospital level. But in general, patient experience, and I reported that, I think, in the introduction section, it's in around between 70s and 80s. So the overall scores or the responses from the patients are or indicating high patient experience and satisfaction, especially in larger hospitals.
And do you expect any selection bias?
Thank you for this question, highly esteemed opponent. The questionnaires for PREMS especially, they are collected for patients at discharge. So whoever responds to the questionnaires, their responses will be included in the analysis. So I don't think that selection bias is an issue here, because they are equally distributed to patients upon discharge.
Yeah, but maybe I don't know which way it would be, but those who are have better experience or have worse, when part is not responding to the questionnaire, you miss people. And we know from measures like this that sometimes it's also there's also a provider component, that the questionnaire is given more frequently to people with better experience than to people with worse experiences.
Yeah, highly esteemed opponent, thank you for this comment. Actually, in the country at this stage, PREMs are collected by an external vendor. It's not, by the hospitals themselves. We have an external vendor, third-party company that collect PREMs, and this is what was used in our studies. Actually, it's by third party. So the contact information is given by the hospital to the third party. They are the ones responsible to collect PREMs data. That's why I a little bit excluded selection bias, because they don't know actually what group of patients they need to focus on, and to maybe to indicate higher rates or higher scores.
Yeah. Okay, thank you very much. I give the word back to the prorector.
Thank you very much, Professor de Jong. The opposition will now be continued by Professor Renneberg, Professor of Promoting Quality and Safety in Healthcare at Maastricht University.
Thank you, Pro-Rector. Dear candidate, also my congratulations to this extensive work, and also to your promoters. I think it's very relevant and in time, because the topic is highly pertinent, especially given the global shift towards value-based healthcare systems that focus on improving patient outcomes while controlling costs. And the choice to study this within the context of Saudi Arabia adds significant value, as the country is currently undergoing major healthcare reforms in this Vision 2030 program. And so this is really in time to help them. And in that case, I also have a few questions that might relate to that. Focusing on chapter 2 first. This is a systematic review, and there you identify and analyze quality measures used in hospital value-based healthcare for cardiovascular disease and cancer. And I wonder, which of these measures do you find most challenging to implement in the Saudi Arabian context?
Hi, esteemed opponent. Thank you very much for your question. Yes, in the systematic review, we identified outcome measures and we classified them into different domains. Now, what I think it's most challenging in the specific context of Saudi Arabia for the time being is the PROMs. PROMs are still in the early stages or early collection in the country in many hospitals. Now, when it comes to, for example, survival or mortality, these are fundamental measures that are considered or collected as fundamental practice in the hospitals. Same for discontinuity of care when it comes to adverse events, complications, hospital-acquired infections. Usually hospitals measure these outcomes, although it's at hospital level, but still measured in the hospitals. But what's new in the country, or the new concept in the country, is related to PROMs. Many healthcare providers and patients are still not aware about the role of PROMs. Some healthcare providers, they just collect PROMs for a matter of collection because we want to implement value-based healthcare. But when it comes to the real use of this data in clinical practice and in shared decision-making, many are not aware about the role of PROMs. So what is challenging at this stage, I think, PROMs and more emphasis and efforts need to be given for PROMs collection.
Yeah, so I agree. PROMs are rather new, also not only in Saudi Arabia, but in all over the world. We are also facing these problems because the healthcare was actually more clinician oriented. So we like to think in terms of life expectancy or life or death or something like that. While patients are thinking about much different. That also raises a problem in convincing the clinicians about how important PROMs are. Do you have any plans for that?
Yeah. Thank you for this question, highly esteemed opponent. Yes, for physicians, training is important, raising the awareness of physicians and all healthcare providers about value-based healthcare and PROMs is really needed. A lot of efforts need to be focus on providing knowledge training. It can be some kind of online or self-paced training for healthcare providers, because, especially for physicians, when it comes to physicians, and this is what we encountered in chapter 4, actually in chapter 5, among the barriers, that the limited time constraints for the physicians would limit their contribution and participation in value-based healthcare. Yet they are interested, they want to be part of that, but because of the workloads, most of their time in the clinics or in OR, in operation rooms. So providing this training and providing resources to give some support for physicians and healthcare providers on site, this would give some free time for them to give for the patients more discussion and elaboration with the patient about PROMs and other outcome measurement areas, even for PROMs also. So this will give them more time to discuss with the patients and reduce the administrative burden related to data collection, data analysis, reporting, and visualization. So this is very important to provide these training sessions in order to enhance their capabilities and enable the transformation.
And do you think this is all the responsibility from the hospitals, or do you think the government also plays a role?
Thank you for this question, highly esteemed opponent. Of course, the government has a major role in this by providing or devising the implementation plans for value-based healthcare. And I wrote this in chapter 5, and it was recommended, by the way, by the CEOs and CMOs interviewed in our study in chapter 5, that it must start from the government, the transformation or the implementation plans, and then cascade it down into hospital levels. Each hospital will take this general implementation plan by the country and customize it based on their context and resources. But it must start from the country. And this what was established again, I want to second what Prof. Abshaiga mentioned about the programs, the training programs that the different entities and institutions at national level are providing for healthcare providers to attend and to gain more knowledge and understanding about value-based healthcare.
Yeah, interesting. And when we look at, for example, chapter 5, you also looked at the barriers hindering the measurement of outcomes. And also there, the question could be, which strategies do you consider most feasible for overcoming these barriers in the short term? Is it also teaching and courses online, creating time for everybody to engage, or do you have other solutions?
Thank you for this question, highly esteemed opponent. One of the most important strategies that can be implemented at this stage is the piloting or low-scale implementation, stepwise implementation of value-based healthcare. People from our findings in chapter 5, they want to see or to listen, to hear about successful stories from other countries, from other healthcare organizations, to showcase lessons learned, even mistakes or successes, good things or bad things, so they learn from it and they build upon others' efforts on this transformation. So this low-scale implementation and showcasing case studies from other countries would help the healthcare organizations at this stage in Saudi Arabia to build to develop their implementation strategies into this value-based healthcare. Of course, standardization is also important. To start with the standardized outcome sets that were developed by others, not to reinvent the wheel, not to create their own. There are standardized sets that they can start with at this stage. At later stages, when they have more advanced programs, definitely they can add to those standardized sets. So the standardized sets are there for some medical conditions, not for all. Yeah, we need to admit, but at least we have some models of standardized outcome sets for different medical conditions with low-scale implementation. I think these are among the top priority strategies.
Yeah, I agree with you that standardization would probably help and to make it as easy as possible and to take away the barriers that we see and help everybody to implement this. Well, I was also very interested in your general discussion, because usually that gives us a little view of the future that you see. And so when you're reflecting on this entire research, what do you now consider the single most critical factor that would accelerate the adoption in Saudi Arabia? You just mentioned some, but what thing should we do tomorrow? And how should the healthcare stakeholders address this?
Yeah. Highly esteemed opponent, thank you for this question. As I mentioned earlier, that at national level, we need to have this implementation plan from at the national level, and this needs to have like actionable insights, steps with clear guidance, practical guidance on how to implement value-based healthcare. The literature is rich with why value-based healthcare, what is value-based healthcare, but when it comes to how I need to say that in the systematic review and even in other literature review that I've done in the studies, it was difficult to find really practical models on how to implement value-based healthcare. So the country at the national level must give this guidance for the hospitals on, for example, which medical conditions are priority in the country based on the population of the country, so they can focus on those medical conditions as first step in this transformation into value-based healthcare, with clear tools especially for PROMs, that we have a lot of tools, generic disease-specific tools. So standardization of these tools at national level would make it easy for the hospitals to adopt which tools to use for PROMs data collection for different medical conditions that are deemed as top priority at the national level.
So I think we agree on small steps, but not giving up, and everybody, the healthcare providers, but also the government, should be in favor and keep the program going. Thank you very much for your answers. I'm very satisfied. I give the work back to the prorector.
Thank you very much, Professor Renneberg. We now come to the last opponent. That's Dr. Van Veghel, Director of the Netherlands Heart Registration. Dr. Van Veghel.
Thank you, and congratulations, candidates and promoters, with this excellent work. I'm very happy to see that the implementation of value-based healthcare in Saudi Arabia is moving forward. But I also have some worries, which I would like to discuss with you. And my main worry starts with the fact that value-based healthcare has been described already almost 20 years ago as a theoretical framework, and still worldwide we don't have best practices that have really succeeded in implementing the complete concept. You just came upon this already. So from that point of view, I think that a focus on the real theoretical basis would be very important. And that's where I have my worries about the position of PREMS in this concept that I would like to discuss with you. Because in the theory, Porter describes together with Thijsberg that value is about outcomes and costs, and those outcomes are really tending towards what you've just mentioned, clinician-reported outcomes and patient-reported outcomes. So my yes or no question would be to you to start this discussion. Do you agree that PREMS do not really have a position in the implementation in value-based healthcare?
Thank you for this question. Actually, I do agree that PREMS have position in the measurement of value-based healthcare, and this was the research question for us in chapter 4, whether PREMS provide an evaluation of the hospital quality of care consistent with other objective measures. So we measured this over like more than 2 years, 13 quarters. We measured this association between clinical outcomes and PREMS, and we ended up with that higher PREMS are associated with lower unfavorable or undesired clinical outcomes. This gives us a hint, really, that PREMS are consistent. So when the hospitals perform better, provide better care for patients in the hospitals, patients will be happier. So when you meet, for example, a patient received healthcare or medical treatment in one of the hospitals, and the patient was happy, this can give us an indication that the care provided in this hospital would be of high level in terms of outcomes.
Well, thank you for this extensive answer. My intention was to ask a yes or no question, but you explained a lot more, so thank you for that. I want to come back to this topic in a few seconds, but I first have a more detailed question about table 4.2 on page 76, which are the data where you just came upon, where you decided to analyze these data per quarter. And I was wondering, why did you decide to analyze this per quarter? Because the healthcare processes, I can imagine, they remain the same the entire year. So what was your thought behind this analysis per quarter?
Thank you for this question. Actually, the healthcare organizations here in the country, they started to implement this value-based healthcare transformation. So there are initiatives ongoing, and there are efforts to improve the healthcare services ongoing. So conducting that annually would underestimate, let me say, or would not capture the effect of these initiatives and efforts that are ongoing in many healthcare organizations. So to ensure that the evaluation of the hospital quality of care in terms of crumbs in this table is captured, so we measured it quarterly to ensure that the impact or the effect of the initiatives are reflected on the numbers, and accordingly we can check the association with PREMS.
Okay, thank you for that answer. That clarifies a lot. My second question regarding the table would be about the data quality. I think from worldwide, the experience is that if you start measuring outcomes in daily practice, it's very important to have high quality of data, because otherwise you are misinterpreting the daily practice. So how was the quality of this data assured? How can you be sure about what is being reported here?
Thank you for this question, esteemed opponent. Actually, at the beginning of this study, we ensured that the enrolled hospitals in the study have a standardized way of measuring outcomes and of measuring PREMs, and this is what this was among the first steps in the study, and we were aiming at that time to enroll more hospitals in the study, but they had different ways of measuring clinical outcomes. So the first step was to ensure the credibility, validity of the data, and reliability, as you mentioned, the accuracy of the data. We started with ensuring that the data collected is standardized across all hospitals included in the study, and of course the measurement practice and the calculation, the formulas used for outcome measurement, and even the data collection was monitored all the time in these hospitals. That's why we used purposive sampling in this study to ensure that the hospitals that are included in the study have this standardized way, accurate way of measuring outcomes. We excluded, by the way, others who have different measurement practices. Now, when it comes to clinical practice, it's an issue. Yes, exactly. It's not about this study. Your question was about like general practice. The accuracy of data collection is very important, and this needs a lot of validation. That's why automation here and IT solutions, which can offer interoperability and integration of data from multiple sources, combination of multiple sources, would validate whether the data is congruent, consistent. When we say PREMs are high, then we have other sources of data that tells yes, PREMs are high. So this interoperability that can be offered by IT solutions is very important to ensure the accuracy and the credibility of the data.
Okay, thank you for your answer. One final detailed question about the table. I noticed that you have chosen to report means and standard deviations. And given the standard deviation that I observe, for instance, in readmissions, where the standard deviation is higher than the mean, I was wondering, were those data standard normally distributed? Or
Yeah.
so,
Sorry.
Yes, go ahead. Go ahead.
Okay, thank you for this question, esteemed opponent. Actually, these indicators that we used in this study were measured as ratios and percentages. And you know, the measurement of ratios and percentages would result in non-normal distribution of error when we analyze them. So we had some skewness and non-normal distribution of some of the indicators. That's why we used the multivariate generalized linear mixed model regression analysis to adjust and to adapt these non-normal distributions in error, and the skewness that we had in some of the indicators induced by ratios and percentages measurement of the indicators.
Thank you. Then for these final minutes, I would like to go back to my first question, because you've now shown that PREMs are related to the clinical outcomes with reliable data, with robust statistics. So my question would be, your conclusion is that clinical outcomes, better clinical outcomes, are associated with better PREMs. So should we not stop measuring PREMs? Because if we have the clinical outcomes available, which are needed for healthcare providers to be able to improve quality of care, then the PREMs, as a result, will improve. So should we not stop measuring PREMs because of the registration burden, etc.?
Thank you for this question, esteemed opponent. Actually, the inclusion of crumbs, and prims in value measurement is needed to have this comprehensive evaluation. As we started this discussion, that what matters to the patient needs to be included in value measurement, and prims and measuring patient expectations and experiences in their hospital journeys and in their admissions would provide in-depth insights about the care provided in those hospitals. So to have this comprehensive and value-based or value-centric evaluation of healthcare services, we need these in-depth insights from different data sources, from clinicians, from patients themselves, as related to their outcomes and as related to their experiences and expectations. By this, we will have this comprehensive overall evaluation of the quality of hospital care that really we need to improve and to transform the healthcare system on what matters to the patients and to improve health outcomes in general.
I do not think that we will come to an agreement on this during this meeting, but that's perfect. My final question would be, how do you envision that the learning from the data, because measuring is just one thing, and if you just step on the wedge, that doesn't mean you're going to lose weight. How do you envision that the data will be used for value improvement?
Thank you for this question, esteemed opponent. Yes, this is a very important question, an interesting question, and it's there in recommendations actually of this dissertation that we should.
Who asked?
Rawia Abdalla, the time appointed for defending your thesis has passed. The degree committee will now withdraw to discuss the quality of your thesis and your defense. I request that you await the results of our deliberations and our return. So, the committee is back. Rawia Abdalla, the committee, present online, has assessed the quality of your thesis and your defense. In view of its positive verdict and taking into account your previous qualifications, the degree committee has decided to grant you the degree of doctor. Professor Groot is authorized to confer upon you this academic distinction in accordance with Dutch university custom. I invite your supervisor to now take the floor.
Do you promise to work in accordance with the principles of scientific integrity at all times, to be careful and honest, transparent, independent, and responsible?
Yes, I promise.
By the authority vested in us by law and in conformity with the decision of the committee here present online, I hereby confer upon you, Rawia Abdalla, the degree of doctor and grant you all the rights attached by custom and law. As evidence of this, you will soon receive the degree certificate signed by the rector, the secretary, and the supervisor, affixed with the official seal of the university, shown now by the beadle. This is it. It's coming your way soon. Congratulations, Rawia. Well done.
Thank you, Prof. Thank you very much.
Dr. Rawia, thank you so much.
Dear Dr. Abdalla, dear Rawia, it is a great honor and pleasure to be the first to congratulate you with your doctorate degree. I also do this on behalf of Milena. Both of us feel proud about what you have achieved. You've written an excellent dissertation that increases our knowledge and insight on value-based healthcare in Saudi Arabia. And you were well able also to defend it, and you had the defense was excellent as well. One of the key elements of value-based healthcare is that payments are linked to achieved outcomes. In your dissertation, you show that there is quite some consensus on what outcomes should be rewarded. Consequently, it's quite clear from the literature as you show what the focus of value-based healthcare should be. This is confirmed in your empirical studies among physicians in hospitals in Saudi Arabia. You find that physicians prioritize survival, quality of life, time to treatment, the incidence of adverse effects, the need for retreatment, and the incidence of hospital-acquired infections as outcomes to be incentivized. Patient-reported experiences are a key element of value-based healthcare. In your dissertation, you show that these experiences, as reported by patients themselves, are highly correlated with better quality of care as measured by lower readmission rates and shorter length of stay at lower infection rates. Experiences as reported by patients are thus a good quality indicator. Finally, when the benefits of value-based healthcare are so evident, why is its implementation so slow? This you have looked at as well. You find that there are barriers to the implementation of value-based healthcare. These include a lack of knowledge and skills about value-based healthcare, competing clinical and business demands, shortcomings in plans and strategies to implement value-based healthcare, time constraints, and inadequate information technology, to mention only a few. This comprehensive approach, where you have looked at value-based healthcare from a physician, patient, and management perspective, is, I think, highly valuable for the further implementation of it in Saudi Arabia. Your dissertation thus comes at a timely moment, as Saudi Arabia has made the development of value-based healthcare a priority in the reform of its healthcare system. I believe that the results of your work are highly relevant and useful for the further implementation of it, not only in Saudi Arabia, but elsewhere as well. Evidence of this is that your papers, although only recently published, are already attracting attention and are being cited by others. For those of you who have not closely followed this PhD trajectory, I must make clear that Rawia did an amazing job. You started your PhD research in the middle of the corona pandemic in 2020. You were able to finish your dissertation in less than 4 years' time. You did this part-time alongside your otherwise demanding job as Director of Nursing Research at the Saudi German Health Hospital in Riyadh. Not only that, you also raise and take care of your 4 beautiful daughters, one of whom was born during your PhD trajectory. On top of that, you have collected data among physicians, patients, and hospital managers for your dissertation all by yourself. Have analyzed the data yourself and wrote some excellent papers on them. This is a truly amazing achievement. You're not alone in that. Milena and I were fortunate as well to be the supervisors of your husband, Mohammed, who graduated last year in an equally excellent dissertation. I don't know whether there is some sort of competition between you and your husband about who writes the best dissertation in the short possible time, but if I were to judge of it, I think it's an equal match. But above all, it's a truly amazing achievement of both of you. As I said, Milena and I were very fortunate to have the opportunity to supervise you both during this PhD journey. If only all PhD candidates were like this, the life of supervisors would be much easier. It was a great pleasure to work with you, not only because of the excellent and highly relevant research that you have done, but most of all because of who you are. We very much enjoyed your positive can-do attitude and your charm and enthusiasm. We keep fond memories of the online meetings that we had, which frequently were a highlight of our day. We also find it a pity that we never had a chance to meet in person here in Maastricht, but we sincerely hope that you will find the time in the future to visit us here so we can celebrate this joyful occasion together in person. To borrow some of your own words from your acknowledgement section, your presence in our thoughts will endure forever. Finally, let me again congratulate you, Dr. Abdalla, with your excellent achievement, also on behalf of Milena. I want to also take the opportunity to thank the members of the assessment committee, both here present here online, for their efforts and work in evaluating your thesis and in providing opposition today. The same holds for the pro-rector. I want to thank Marlene as well for being the chair today. I also want to extend our congratulations to your husband, your children, and to everyone else who has taken the time to watch the live stream and virtually celebrate this joyful event here with you today.
Thank you very much.
Dear Dr. Abdalla, also on behalf of Maastricht University, I would like to congratulate you with the degree you have acquired. I also congratulate your family, friends, colleagues, all that supported you on your PhD trajectory in one way or the other, because a lot of people are important to reach this aim. I'd like to congratulate supervisor, Professor Groot and Professor Pavlova, with this beautiful PhD thesis. I'd like to thank also the committee members for their time and their presence here online during this PhD ceremony. Your contribution is very much appreciated by Maastricht University. Of course, as Professor Groot already said, it's a pity that you couldn't be here live to see our university and see the city of Maastricht. But I still hope that you were able to really enjoy the day, the rest of the day, celebrate with people who are dear to you. And I wish you all success in your future career. And I hereby declare this ceremony for ended.